you come see about me. I'll be alone, dancing with no one. Tell me your troubles and doubts, giving me everything inside now. Well, your love string so real in the dark. Think of the tender things that we were working on. The slow change will pull us apart. When the light gets into your heart, baby, don't you forget about me.
Wonderful, Chris. Absolutely.
Don't you forget about me. Will you stand above me? Look my way, but never love me. Rain keeps falling, rain keeps falling.
Good morning, everybody. Thank you and welcome to the Edinburg Conference Center at Renaissance and to the 2015 Alzheimer's Summit that we're having here. We're welcoming our guests. And on behalf of Doctors Hospital at Renaissance and Renaissance Behavioral Center, thank you again for being here and spending some time out of your busy schedules to come and attend this conference. Very important. Bathrooms as you walk in the front of the building, you're walking back out, they're going to be on your right hand side. Some on this hallway, keep going clear to the end, to the left hand side. There's bathrooms there as well. Few housekeeping rules. Silence your cell phones, please. There's refreshments, coffee, water, assorted drinks, and then we're gonna have a lunchbox. Lunch today, and then some PM snacks. So, thank you again. My name's Esther Fuentes. I do business development for Doctors Hospital at Renaissance. We do have some information in the front of the entryway in the foyer. Please take a lot of information back with you, share it with all your co-workers, with the community. And again, thank you for being here and taking time out of your busy schedules. Anne Cortez, we welcome everybody here today. Thank you. And there's a little blue ticket if you don't have. We're going to do door prizes at the end of the day. So make sure you stick around at the end.
Thank you. Good morning.
Hi.
And I'm going to try not to touch this because I don't do well with that. My name is Ann Cortez, and I am the Regional Director for Adult Protective Services here in Region 11, which encompasses the 19 most southern counties of Texas. And I'm going to try to stay away from that because I don't do well with this either. We are very, very proud to be working with UT Health Science Center in San Antonio, the Alzheimer's Association, and Doctors Hospital in putting this conference together for you this morning. You will be learning about Alzheimer's and dementia-related disorders this morning, and it is a full day if you have looked at your agenda. This is a rare opportunity, and I'll tell you why it's rare. One is that it's a full day. Two is that it offers you CEUs. Three is that it provides you a continental breakfast, a lunch, and snacks, all for the very low price of free. And you can't get that anywhere. So please, if you have the opportunity, thank Health Science Center of San Antonio, those representatives that are here, Esther from Doctors Hospital here at Renaissance, who has been so generous, and the Alzheimer's Association for providing this for us. The venue is state-of-the-art, and we are very lucky to have it available to us and to you. Adult Protective Services, I'm sure that either fortunately or unfortunately, many of you have had some experiences with Adult Protective Services. Our mission is to protect the elderly and adults with physical disabilities from abuse, neglect, and exploitation. And I have some of my APS staff here with us today, and if you're here, I'm going to make you stand up. Now. Some of them might be outside, right, manning the booth, because I saw more of them. And I already got one referral this morning when I walked in. So these are you see some of them are walking in. These are the folks that conduct those investigations of abuse, neglect, and exploitation here in the Rio Grande Valley and the 19 counties in the Lower Rio Grande in South Texas. This last year, Hidalgo County receives the highest amount of referrals in all of Region 11, Nueces County following that, and then Cameron County. And of the over 2,000 referrals that we receive of abuse, neglect, and exploitation, about 70% of those are, we find some validity. And we try to provide services to those cases. So we are finding more and more that it's becoming increasingly difficult to provide services in these cases of abuse, neglect, and exploitation without our community partners. Because we can't be in there 24 hours a day, you can't be in there 24 hours a day. So it really takes a very strong collaborative effort to address situations of severe neglect, situations of exploitation, and situations of physical, sexual, emotional abuse. So when dealing with these situations, please report it. And when working with our caseworkers and investigators, please work collaboratively with them and help us with these type of very severe cases so that we can provide services to them to best meet their needs. We have over 250 people registered today, and I anticipate that probably some will be walking in here a little later from all disciplines. We have social workers, we have physicians, we have daycare center staff, we have folks from nursing. So I really hope that I anticipate that there will be evaluations at the end. Gustavo? I really hope that you provide us feedback in the evaluations at the end so that we can make some decisions about whether this is valuable to you, whether you feel that we can, what type of information we can provide to the Valley and what your needs are with respect to information. And I certainly do hope that you enjoy this conference. And now I will hand it over to the gentleman from UT Health Science Center who will be presenting our speaker. Thank you.
Thank you very much, Ms. Cortez. Thank you. Please remain seated, thank you.
Please don't stand.
Okay, I'm gonna use this thing as a stand and see how that works. Okay, what I'm gonna do is I'm gonna talk about paperwork and other important information here. First of all, I'd like to thank Esther Fuentes for allowing us to come into her beautiful home, using her facilities and using her staff. Thank you, Joseph, for the AV, Chris for handling today's audio and video, Mark Johnson, Mark Partner, teammate, doing the video recording of this. The DVD for this conference, because he's recording it, will be available. So if you want it, it has all the PowerPoints, I have video, I have pictures and information, so I'm going to fill that out and turn it in the front at the end of the conference, or sometime during the conference. We'll gladly take that from you. And we'll have that mailed to you as soon as we can, depending on the volume, how many we get back. A couple of pieces of paperwork that were given to you were the participant profile. This is a front and back sheet. People in the past, our previous conferences, have filled this out, given us their demographic information, and we have given this to the federal government, and in turn we have received grant monies, and those grant monies provided this free conference. So if you can do the same for our future conferences to provide that for a low cost or even free, that would be great. Kind of pass it forward and pay it forward. So this conference was provided because people previously have filled out the information. So the more information, the better. This is completely voluntary. You can put as much information as you want or don't want, and that's completely up to you. By show of hands, who is looking for continuing education credits today? Wow, just about everybody. Okay, I'm going to be busy. Okay, this is a 2-page paper called the Statement of Attendance. On the first page, it just shows you the CEUs that I'll be providing today. The page behind is the page that you'll be giving me at the end of the conference. I will accept it only at the end of a conference. Your attendance must be 100%, not 99.9, 100% to achieve full credits for today. So you put your signature, your name, your email address, and you're going to check off which CEU you like. And at the end of the conference, you're going to give that to me. And then what's going to happen is, a couple of days later, I'm going to email you an electronic evaluation. You complete the evaluation. A couple of days later, I will email you your certificate. Now, I'll be up and around all over the place, so if you have any questions pertaining to CEU or anything else about this conference, come find me. I'm easy to talk to you, and I'll work with you, and I want you to get your certificate, your credits as soon as and accurately as possible. So I'm right with you right there. I'd also like to thank Doctors Hospital at Renaissance for all their contributions. They've been very generous with us, again, for providing this very wonderful and brand new facility with all the high tech. I'd like to thank Renaissance Behavioral Center for their support for bringing this conference to McAllen-Edinburg to provide you this free conference. Thank you very much, APS Region 11, and definitely to Gustavo for all your help and your hard work in making this conference possible. Thank you so much for your diligence and your quick responses through email. Sharon Rice and the South Texas College, thank you so much for being part of the team and for handling your volunteers. Shanta, Iris, Clarissa, Valerie, Melissa, and Anna, thank you so much for donating your time. If you're divorced, sorry about that, you're stuck for today. So, and yeah, and then I'm gonna introduce our speaker who's been standing here waiting. And this is Dr. Jason Schillerstrom.
We want to hear more rules.
More rules? Okay, all right.
More rules.
Okay, you must remain seated. Trey in the upright position. Okay. Dr. Jason Schillerstrom, MD, is a associate professor with tenure at the University of Texas Health Science Center in San Antonio, which we call UTHSCA. He completed his medical school, psychiatry residence, and geriatric psychiatry fellowship at UTHSCA. Dr. Schillerstrom is the director of psychiatry residency and training, and he established and directs the UTHSCA Geriatric Psychiatry Clinic that specializes in cognitive impairment and depression in elders. His clinic serves as an interdisciplinary training site for medical students, psychiatry residents, pain medicine fellow, and nurse practitioners. In addition, Dr. Schillerstrom is a primary physician, primary psychiatry consultant for Texas Region 8 Adult APS, where he performs forensic psychiatry evaluations and studies cognitive correlations of delusional incapacity, self-neglect, and financial exploitation in vulnerable elders. So please help me in welcoming Dr. Jason Schillerstrom.
So I agree with Anne. This is going to kill me. So I'm going to step down here. So again, thank you so much to Doctors Hospital Renaissance for donating this incredible space. I've given talks all across the country in all these metropolitan areas, and I've truly never been in a venue that is as beautiful and as modern as the one we're in today. So thank you so much to DHR for donating this incredibly beautiful venue. And thank you also to Adult Protective Services for helping to host this event. As a matter of background, I'm a geriatric psychiatrist. That's really what I am. I'm a geriatric psychiatrist. I'm the residency training director in San Antonio. On July 1, I'll have 70 residents. We have about 70 residents in our training program in San Antonio. A third of those are active duty Air Force psychiatry residents. So if you ever wondered where do Air Force psychiatrists get trained, it's actually in San Antonio. It's in our residency training program there, just north of here. So I do the residency training program. I have an outpatient clinic, but the day of the week that I enjoy the most is Wednesday. On Wednesday is when I get to work with Adult Protective Services. And so to be able to come here and talk with APS and all of their community partners, as Anne was saying, is just an incredible privilege and treat for me. So thank you so much. This morning we're going to set the stage by talking about Alzheimer's disease and other related dementias with the new classification system, DSM-5. The word dementia is out. That's like so yesterday. And it's been replaced with a whole bunch of other more words called major neurocognitive disorders. So we're going to distinguish between, we're going to talk about DSM-5 updates and talk about what dementia is, now kind of renamed major neurocognitive disorder. And really what we're going to focus on through some kind of case-based examples is how to distinguish between these different disorders. So really this morning what I want you to learn in the first hour is what major neurocognitive disorder is, formerly known as dementia, and start to learn that there's more than one kind. It's not just Alzheimer's disease. There's lots of different types of dementia, and we'll talk about what the different qualities and characters are with each of those. After that, I'm going to talk about capacity. So the work that I do with Adult Protective Services is I assess decision-making capacity for them. Every Wednesday, APS picks me up at the doorsteps of the University of Texas and whisks me out into Region 8, which has 28 counties stretching from Port Lavaca to Del Rio, and we assess and root out decision-making and capacity in that area. We'll then have a lunch break. We'll talk about kind of the pharmacological management of dementia after that, and we'll end with alcohol use disorders, because if I can make it to the end of the day, I am going to need a drink, and so are you. So we will end with alcohol use disorders. Okay? All right, here we go. So first, financial. I don't have any relevant financial disclosures. This was funded by a publicly funded grant for us to be here. For the first part, we're going to talk about the diagnostic criteria for major neurocognitive disorder, talk about different cognitive impairments, describe the clinical, pathological, neuropsychological features of each of these different types of neurocognitive disorders, and then just start to think about how we can distinguish between the two, or I'm sorry, between the four that are listed. So to begin with, this is the new DSM-5 criteria for major neurocognitive disorder. Those of you that remember DSM-4, right, might remember that it was listed as dementia and dementia-related disorders. And there was the first criteria. So the first criteria was, does anybody know, does anybody remember what the first criteria was to have dementia? If you had dementia, you had to meet criteria 1, and criteria 1 was what? Do you remember? It was memory impairment. You had to have memory impairment, right? You had to have memory impairment. And that was based really on the idea that it was sort of the Alzheimerization of these dementia disorders. And another important sponsor, if you will, here today is the Alzheimer's Association, which will always clearly state that that they are there to support families, patients with Alzheimer's disease, but also those with other dementias as well. And so Alzheimer's disease is clearly marked by memory impairment, but the other dementias, some of them, not so much, right? And so I'm sure in a group like this that you've seen patients who just seem to not be cognitively getting the job done, and yet their memory doesn't seem that bad, right? Their memory just doesn't seem that bad. And so, so this was, when the APA redid their criteria, they got rid of the idea that memory had to be impaired. Memory doesn't have to be impaired anymore. You can have other cognitive impairments. So there has to be evidence of significant cognitive decline from previous levels of performance. There has to be concern of the individual, someone else, the clinician, that there has been decline. And then the catch is that the cognitive deficits have to interfere with instrumental activities of daily living, IADLs. Okay? So what are examples of instrumental activities of daily living? What are examples of those? Say that again? Community mobility, so like arranging for, providing for transportation in some way. That's exactly right. What else? What's that? Care of others? You don't have to be able to take care of other people. But you have to be able to take care of yourself. Right? It's like what? Huh? Bathing and grooming? So bathing and grooming are basic activities of daily living, right? So the basic activities of daily living are things like bathing and grooming, feeding yourself, walking, ambulating, toileting. Basic activities of daily living are those skills that allow you to survive in your home, right? In your home. Instrumental activities of daily living are kind of a higher order function. It's doing housekeeping, laundry, cooking, shopping. As was stated over here, transportation, financial management, medication management. So you can think of instrumental activities of daily living as that set of skills that allow you to survive sort of in the community, right? So we do not have to wait for someone to be bedridden, not ambulatory, not able to manage their toileting. We don't have to wait for basic activities of daily living to be impaired. People develop these dementia, major neurocognitive disorders, when IADLs are impaired, right? Once instrumental activities of daily living are impaired, then we start to think about dementia-related processes. And so then the cognitive impairments have to explain or be the cause of the functional impairments. So really what major neurocognitive disorder is, what dementia is now, is that you have a cognitive impairment, you have a disability, and the cognitive impairment is what explains the disability. That's it. Right? There's a whole lot of words on the slide to say that it's disability mediated through cognitive impairments. And so I always tell people, I always tell my medical students, my residents, that there's 1,000 ways to be demented, right? There's 1,000 ways to be demented. And so without a doubt, I think Alzheimer's disease is the type of dementia that a lot of people are very familiar with, and it's kind of most known and certainly most studied. But it's not the only dementia. There's Alzheimer's disease, there's frontotemporal dementia, Lewy body dementia, dementia secondary to cerebral vascular disease. There's all different types of dementia other than Alzheimer's disease. And each of these dementias can be just as debilitating, just as impairing, can limit function just as much as Alzheimer's disease can, okay? And so the four we're going to focus on today are the top four: Alzheimer's, frontotemporal dementia, Lewy body disease, and vascular dementia. And that's not to say that the others aren't important, it's just those are the four that I see the most in my clinic, right? So I have a geriatric psychiatry outpatient clinic. Those are the four that in my clinic I see the most. I think neurologists would certainly see much more Parkinson's disease, Huntington's disease, HIV infection, and traumatic brain injury. But in geriatric psychiatry, I tend to see the top four. Okay, and so then these dementias, these major neurocognitive disorders, can be with or without behavioral disturbances. And behavioral disturbances are things like agitation, aggression, apathy, psychosis, that kind of thing. And then they're classified as either mild, moderate, or severe. So if it's a mild dementia in DSM language, your disability is limited to IADL impairment, right? If it's moderate, then your disability includes trouble with the basic activities of daily living, the walking, the ambulating, the feeding, the bathing, the grooming. And then finally, essentially bedridden would be severe. So that's the classification as it is now. So as we kind of start to think about the first kind of learning points this morning, the first thing I have to stress is that the diagnosis of dementia or major neurocognitive disorder is based completely on the clinical interview. It's based on the clinical interview. There is no dementia lab. So you'd see in those criteria, there's no laboratories, right? There's no dementia MRI or CAT scan. There's no dementia test, not even a cognitive test or any other kind of neuropsychology test. The diagnosis of dementia or major neurocognitive disorder is based completely on the clinical interview with the patient and other collateral information, right? Family members, friends, whomever, okay? So dementia there's, you can't escape the clinical interview. You have to interview the patient. There's no way. And then what we do is we use the labs, we use the MRIs and the labs to make sure that there's no potentially reversible cause of the major neurocognitive disorder. So for example, you can imagine that if you have hypothyroid and your thyroid levels are super low, that you might have cognitive problems from that. Those cognitive problems could be causing your functional problems, and you would meet the definition of major neurocognitive disorder, right? But we don't want to diagnose you with that. We don't want to treat your hypothyroid disorder with Aricept or any other acetylcholinesterase inhibitor. So we're going to do some labs just to make sure that there's no reversible causes, right? We don't want to diagnose someone with a urinary tract infection with dementia. That would be terrible. Okay. And then the last thing is that there has to be clinically significant functional impairment. There's a lot of patients who will say, you know, I just can't, I don't remember names like I used to. Some other kind of sort of cognitive. They'll describe these sort of cognitive nuisances, but unless you're functionally impaired, you don't have dementia or major neurocognitive disorder, no matter how bad your cognition is, right? So you can imagine that you could be amnestic. You could have amnesia. You could have been hit on the head and have amnesia. But if you are able to meet all of your basic and instrumental activities of daily living, well, you don't have dementia. You just have amnesia, right? Right. So you have to be functionally impaired. Okay. The next group of slides talks about cognition and all the different types of cognition. And in the next 6 slides or so, what I'm really wanting to illustrate is that there's more to cognition than memory. So memory is certainly a cognition. Complex attention would be a cognition. What other cognitions could there be? What else? Other than memory and complex attention. What else? Is that like math? Is math a cognition? Yeah, sure. Like math's a cognition. What else? Maybe reasoning abilities when we start to think about executive function. So executive function and reasoning and planning and organizing, that's a cognition, absolutely. Orientation, right? Knowing the date, the time, the place, all that kinds of stuff, right? That would be an example of a cognition. So there's so much more to cognition than just memory. So many times patients will come to you and they'll be saying that they're having memory problems. You'll do memory testing and their memory will be fine. And you'll say, well, you know, you're not having memory problems, but these other cognitive impairments can feel like memory problems even when they're not. Okay, they can feel like memory problems because patients, you know, no patient will ever come to you and say, you know, I'm really having a problem with my complex attention. Right? Wouldn't that be nice if they did? You know, my complex attention, it's just not what it used to be. So I wish they would, but they don't. Okay, so complex attention is one cognition. It's your sustained attention, divided attention, processing speed. When people start to have kind of minor, subtle, non-debilitating problems with complex attention, you'll see that they require more double checking than previously. Thinking is easier when they're not distracted by the television or the radio or something else. Where we start to see disability, where disability can start to emerge, is when they're put in new environments, they're distracted when they're asked to hold information, and then all thinking just seems to take longer than usual, right? It just seems to take longer than usual. So probably kind of the classic example might be when a family's going out to dinner at a restaurant that they've never been to before, and the elders handed a menu, and they just kind of stare at it for a long time, right? A long time. They just can't seem to focus, and then what do they do? What do they do? They say, well, I guess I'll have what my daughter's having, right? That's what they do, right? They say, well, let the daughter order first, and I'll just have what she's having, right? So that would be problems with complex attention. Learning and memory. So this would be immediate memory recall, remote memory. So early on, what we'll see is that patients will start to require a little more dependence on lists. They need a few more reminders. They kind of lose track of if the bills are paid or when they're paid, so they start to enroll in automatic payment plans, automatic payment plans. When we start to notice disabilities, when they start to repeat themselves in conversation, they're asking the same questions again and again, they can't keep track of short lists of items, right? So in the differential diagnosis of the major neurocognitive disorders, probably the first branch in the tree is trying to figure out, does the patient have promptable memory impairments, or do they have non-promptable memory impairments? That's like the first branch that we're trying to figure out. What do they have? Do they have promptable memory impairments or non-promptable memory impairments? So an example of this is that I might have a patient who, they come into the clinic, they're telling me they have memory problems, and so I might say, okay, well, I'm going to give you 3 words that I want you to remember. The 3 words are whatever, apricot, table, penny. Apricot, table, and penny, whatever, okay? So I'm going to tell them, I want you to remember these 3 words, apricot, table, and penny. I'm going to ask you in a minute what they are, and then I'll have them, whatever, spell world forwards, spell world backwards, and then I'll say, well, what were those 3 words? And they might say, well, I don't know. And I'll say, well, one of them was a piece of furniture. And then they'll say, oh yeah, that was the table. Now I remember, that was the table. So that's an example of a promptable memory impairment, right? It's like, oh yeah, okay, well, what were the others? I don't remember. Well, one of them was a coin. Oh yeah, the penny. Now I remember, that was the penny, right? So in Alzheimer's disease, do Alzheimer's disease patients have promptable or non-promptable memory impairments? What's that? Non-promptable, that's exactly right. Patients with Alzheimer's disease have non-promptable memory impairments. When I show you the pathology of Alzheimer's disease, one of the places the pathology, the tangles attack, is a structure called the hippocampus. The hippocampus is the part of your brain, it's in your temporal lobe here, it's the part of your brain that encodes new memories. So that part of your brain becomes diseased, doesn't work anymore, you can no longer encode new memories. So because you can't encode the new memory, it doesn't matter how many hints or clues I give you, the memory never comes back because you never encoded it in the first place, right? So patients with Alzheimer's disease have non-promptable memory impairments. So this would be in contrast to Parkinson's dementia, right? So dementia secondary to Parkinson's, right? So patients with Parkinson's disease, is their hippocampus affected? No, it's not. Their hippocampus is spared. So a patient with Parkinson's disease may not remember the words, but if I say, well, one was a fruit, they'll say, oh yeah, that was the apricot. So they don't have a problem with encoding new memories, they have a problem with retrieving memories, right? With retrieving memories. So illnesses like vascular dementia, Parkinson's dementia, Lewy body dementia, frontotemporal dementia, these other dementias, often they'll have promptable memory impairments. They're the ones whose memory just doesn't seem that bad. It doesn't seem that bad. Okay. All right, so that's about memory. Language, Early on, we'll see noticeable word finding difficulty, some grammar errors. What's word finding difficulty? What does that mean? What's an example? Can someone give an example? Somebody's name. So that could be true. Names are a little bit different, but you're on the right track. That could be true. So, word finding difficulty might be like when I say, what is this called? What's this called? And they might say, oh, well, that's a clock. Well, it's a clock. It's not a clock. It's like a clock. You tell time with it. That's what you tell. You tell time with it. It's like a clock. And you can just kind of see watch on the tip of their tongue. And you just want to go in there and you want to like pull out that word. Say, it's a watch, right? But so that would be word finding difficulty. It's not. It's having the word on the tip of your tongue and you just can't get it out, right? So we'll see that very early on. As the illness progresses, though, people become much more aphasic. They start to use terms such as, well, it's that thing, that thing that you tell time with. They'll kind of try and kind of cover, if you will. They start to prefer lots of pronouns. Instead of saying people's names, they prefer lots of pronouns. And then eventually they can just develop full-out just kind of mutism where they just lose speech centers. So the part of your brain that allows you to express speech is called Broca's area. Broca's area is right here in your left frontal lobe. It's like right there. And when people start to, when dementia pathology starts to affect Broca's area, you can no longer express words, right? So kind of the classic test of this would be repeat what I say, no ifs, ands, or buts, right? Repeat what I say, no ifs, ands, or buts. And patients with these language disturbances will say things like, well, no ifs, ands, and ands, and buts. They just kind of stumble all over themselves. And that specific phrase is chosen because it forces you to use words as nouns that are not commonly used as nouns, right? No ifs, ands, or buts. You're forcing the patient to use words as nouns that are not commonly used as nouns. And so that's why they'll tend to struggle with that specific phrase more than others. Perceptual motor problems, early on, they may need more directions from others. They might, if they're not concentrating, they might find they're getting lost. Less precise in parking. This is always one of my favorites when my medical students, sometimes I'll have a patient who just has all these bags and stuff, and I'll ask one of my students to go out to the car, help them out to the car, carrying whatever they brought in. And the student will come back and they'll say, oh my God, you wouldn't believe how the car was, they were like taking 3 parking spaces or something like that, right? So I just put less precise in parking, right? And so anyways, okay. And then as the illness progresses, then they have a much harder time navigating new environments, right? They just can't. Now they're really getting lost. They just can't find their way, even in familiar environments. Social cognition. So early on, so this is kind of a new cognition that's sort of starting to emerge within psychiatry, psychology. I say new; it's been around a long time, but now it's getting officially recognized, documented in DSM-5. So less able to read facial expressions, decreased empathy, increased extroversion or introversion. And so that's what we'll see early on. And so clearly out of the, as the illness progresses, now people will be just sort of clearly out of the acceptable range of social behavior, insensitive to social standards and conversation. So they start kind of making kind of crude sex jokes or whatever. Focuses excessively on topics despite others' disinterest. So they'll kind of go on and on and on about a topic, and everyone's kind of looking at their watch saying, right? So, for example, I have a patient whose granddaughter was murdered, right? I have a patient whose granddaughter was murdered. And so the patient's in the exam room, and the patient's daughter, the mother of the murdered daughter, is there, as is her husband. So it's kind of this family in this room, and so I'll ask the patient. I'll say, well, how's everybody doing? How's your family doing? And the patient says, oh, everything's great. Everyone's doing fine. No problems. We're all good, right? Despite this incredible tragedy that's happened within the family, right? So clearly decreased social cognition. Executive function. So we're going to spend like the whole hour following this talk on executive function. I'm not going to talk too much about it here, other than to say it's your ability to plan, organize, sequence, monitor, and inhibit complex goal-directed behaviors. So you can think of executive function as problem solving ability, sort of analogous to problem solving. So memory is on the sides of your brains, right? But executive function or problem solving is right up front. That's frontal lobe. That's a frontal lobe cognition, right? And what we'll see is that when people become executively impaired, when they cannot problem solve anymore, what happens is that they become trapped by their habits and their routines. So as long as they're in their habits and their routines, they're generally okay. But where disasters happen is when those habits or routines are broken, right? So driving, I think driving is a good example, right? And so if they're in the same, the same Buick that they've been driving for the same 20 years, and they're going to the same HEB that they've always gone to at the same time of day, and there's no other distractions, the truth is that it'll go fine most of the time, right? Most of the time it goes fine. So when disasters happen is when the habits and routines are broken, right? So when their children buy them a new car for their 50th wedding anniversary. Ooh, right, that's when the accidents happen. When this HEB doesn't have what they need and they have to go to another grocery store. When they have a grandchild crying in the back seat who's not normally crying in the back seat, right? So disasters happen when the habits and routines are broken, right? People who are executively impaired are sort of trapped by their habits and routines. This becomes a real challenge with APS work when it comes to capacity assessments. Because we might walk into a house and the house is just a disaster, for example. And someone might say, well, he's always lived this way, right? He's like, this is just how he lives. He's always lived this way. He's always been messy, right? And so then what we as clinicians have to decide is, are they living this way out of choice, or are they living this way because they can no longer choose to live any other way? Now they're living this way out of habit and routine, but not out of choice. And that's that can be a real hard thing to figure. So executive function, we'll talk a lot about that in the next hour. So the key point that we're going to make after that series of slides is just for the audience to recognize that there are multiple cognitive impairments. It's not just memory, right? Memory is important, but so is executive function, visual spatial, perceptual motor, social cognition. It's not all about memory. So whenever I hear somebody say, they're not doing well at all, but when I talk with them, their memory seems okay, I always think, well, okay, so what? What about their other cognitions? Are those okay? And they're usually not. And usually they're executive impaired. And so executive function, as we're going to talk about next, is the cognition that most strongly associates with self-care ability and decision-making capacity. And I want to plant that seed now, but I don't want to talk too much more about it. Instead, let's talk about just some case examples and see what we can learn from them. So in the first case example, we have an 83-year-old woman comes to the clinic with her 2 daughters. So 83-year-old woman comes to the clinic with her 2 daughters. The daughters are concerned that their mom is repeating her conversations, telling the same story over and over as if for the first time. The mother cannot remember the names of her grandchildren. She struggles to remember the names of her grandchildren. So that she uses pronouns, right? Well, that cute one right there, him or her, or, my sweet little grandbaby girl, and I have no idea what your name is, but okay. So lots of pronouns being used. And actually what triggered the event was when she became confused and disoriented at a shopping mall. So they went shopping together, and they decided to split up, and the daughter was going to go somewhere and get something, and the mom was going to go somewhere and get something, and the mom just got confused and disoriented, and actually it was like a security guard that found the elder woman and had to had to do a Match.com hookup again. So with her daughter. So the patient's husband died about a year previous to me seeing the patient, and the daughters were just surprised at how much they have to help their mother, right? So the patient's husband died, and now all of a sudden the daughters are just like, I can't believe everything the dad was having to do for mom. When we kind of talk about their past history, the lady has no past psychiatry history, hasn't ever been given a psychiatry diagnosis, psychiatry medicines, no hospitalizations, nothing like that. The only medical issue is that she has a little bit of high blood pressure, treated with hydrochlorothiazide for that. But otherwise, like, really medically healthy. Retired teacher, had been married for 55 years, has 2 children, no substance abuse issues. And so we kind of get all this history, and then we do neuropsych testing. So then just to walk you a little bit through the neuropsych testing here, one of the things you'll see here is a clock. So what we'll do is we will challenge the patient to draw a clock for us. And this is clocks 1. So the instructions for this clock were, I want you to draw a clock that says 1:45 and put the hands and numbers on the face so that a child could read them. So draw a clock that says 1:45, set the hands and numbers on the face so that a child can read them. And so you can see what the patient did. She went, okay, well, all right. She drew the circle, right? And then 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Why'd she do that? Military time? No, that's a good idea. Never been in the military. It's a good idea, though. I like the idea. Why'd she do that? So this is an example of behavior being controlled by habit, right? So when people become executively impaired, their habits start to control their behaviors. And what you see here is that the habit is just to keep going. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, right? And so this is an example of executive impairment where where habits are controlling her behavior. She is not behaving independently from her habits. So she just keeps going, right? And so that would be clocks 1. So clocks 1, that's a failing score. We'll talk a little bit more about clock drawing, but just know that she cannot draw a clock when told what to do, right? The instructions, draw me a clock that says 1:45, set the hands and numbers on the face so the child can read them. She fails that task, and that's an executive function task. That's executive function right there. Then what we do is we say, okay, now what I want you to do is I'm going to draw a clock, and I just want you to copy what I drew. I just want you to copy what I drew. I'm going to draw a clock, and you're just going to look at my picture of a clock, and you're going to copy it, okay? And that would be clocks 2. Clocks 2 is also scored from 1 to 15. The failing score on that is below a 12, so she fails that as well. She can't copy a clock. So she can't draw a clock to command, nor can she just look at one and copy it. So where did I tell you that executive function lives in the brain? Where is that? Frontal lobe, that's right. So from this clock right here, what you know is that she has frontal lobe impairment. You know that this part of her brain is offline. You know that. You also know that she can't copy a clock. So what part of your brain is just looking at something, a cube, a clock, whatever, just looking at something and copying it? What part of your brain does that? What part of your brain just looks at something and copies it? Do you know? What's that? The back? Yeah. So right here, right posterior parietal cortex. Right posterior parietal cortex can look at something, that's visuospatial ability, looks at something and can copy it. So what you know about this lady already, just from these silly clock tests, is that her frontal lobe is offline, and you know that her right parietal, the posterior part of her brain is offline as well. Those of you that are familiar with the geriatric depression scale, it's scored from 0 to 15. It asks questions like, are you happy most of the time? Are you in good spirits most of the time? Do you often feel helpless? Do you often feel worthless? It asks those types of questions. And what I would tell you is that she's not depressed. That's a super low score on the geriatric depression screen. The mini-mental, some of you might be familiar with the mini-mental state exam. It's scored from 0 to 30. The higher your number, the better you're doing. What's the cut point for a fail on the mini-mental? For a fail. The high score will be a 30. But when do people fail the mini-mental? Do you know? 24, right? So at 24, they start to fail the mini-mental. The mini-mental asks questions like, what's the date today? It asks 5 questions related to orientation to time. You have to know the date, the day of the week, the month, the year, the season. It asks 5 questions related to orientation to location. You have to know the city, the county, the state, the floor that you're on, and the name of the building you're in. It asks memory recall. It asks you to spell world backwards. It asks you to copy intersecting pentagons and say no ifs, ands, or buts. So it's kind of a multitask assessment of general cognitive function. On the forms that I have to fill out for capacity, the CME forms, there's a question on there that says, was an MMSE administered? That question, I'm ready to pull that question off, but that question is still on that form. And so the MMSE is clearly, it's the most widely used neuropsychological test that there is. So the cut point for a fail on it is a 24 or below, and so she's failing it. And so essentially she's failing every cognitive measure that we're giving her. To make a long story short, she's failing all these cognitive measures. So what is her diagnosis? Does she have major neurocognitive disorder? Yeah, she's functionally impaired. She clearly has cognitive impairments that are mediating this functional impairment. Daughters are having to care for her, get more involved. So what type of dementia do you think she has? Vascular, maybe? Okay, could be vascular. What else? You know? So this is classic Alzheimer's disease. This is classic Alzheimer's disease. And so, so in classic Alzheimer's disease, some of the hints and clues are just sort of the timing. Now, the daughters who weren't spending a lot of time with her weren't really aware of the level of disability that that she had. And so we'll see this all the time, right? Where the stay-at-home spouse is clearly aware of all of the help that he's having to give the loved one. But the people that kind of visit infrequently aren't really certain. And one of the clues to Alzheimer's disease is that it just has this it sort of creeps up on people, right? It sort of has this insidious onset. And so when we ask patients, or when we ask patients' family members, when did you first start to notice problems? If there's 3 family members in the room, we will get 3 different answers, right? We'll get the daughter number 1 will say, well, I remember about a year ago she came over to my house for Christmas and I noticed that, she was doing something odd or not correct. And then another daughter will say, or a son will say, well, I remember like maybe even a couple years ago, she couldn't remember the name of my son. And the husband will say, well, I remember 4 years ago when this, right? So it kind of, it's a diagnosis that just sort of slowly creeps up on people. And if you have family members in the room, you often get a different answer to that question from each family member. So this is in contrast to like vascular dementia, even Parkinson's dementia, where all of the family can generally agree when they started to notice disability. The other thing that you'll see is, what about her medical history? There's like not much to it, right? There's not much to it. So the other truth is that patients who have Alzheimer's disease, who truly have Alzheimer's disease, they're always strangely healthy, right? They're strangely healthy. If it weren't for this little bit of hypertension, she would be fine, right? She would be fine. Patients with Alzheimer's disease, their past medical histories are just unusually healthy. They're not the ones that are taking gobs and gobs of medications. So in contrast, this would be in contrast to like vascular dementia, where you ask them what their past medical history is. Well, they have hypertension, they have hyperlipidemia, they had a heart attack 3 years ago. You know, their medical problems go on forever, right? Their medical problems go on forever. And so she's strangely healthy. And then the last thing that you see here on the neuropsych testing is that every part of her brain is affected. Every part. When we do the neuropsych testing, she has pan-cortical cognitive impairments. And that's Alzheimer's, right? Alzheimer's disease affects the whole cortex of the brain. It affects the whole cortex. No part of the cortex is spared. The motor strip is spared until late in the disease, but even it eventually succumbs. Okay? So in the neuropsych testing, she has frontal lobe impairment, she has parietal lobe impairments, everything is impaired, right? And that's what we see in Alzheimer's disease. So Alzheimer's disease characterized by this insidious onset, gradual progression of impairment in multiple cognitive domains. Memory loss is the kind of core cognitive feature of cognitive impairments. And again, for Alzheimer's disease patients, do they have promptable or non-promptable memory impairments? Non-promptable. Doesn't matter how many hints or clues you give them, those memories don't come back. And that's why they say the same story over and over again and ask the same questions over and over again, because they never remember that they asked those questions and told those stories to begin with, right? That's non-promptable memory impairment. It's classified into either early onset or late onset, depending on if you got it before or after the age of 65. The only reason that's important, early onset versus late onset, is people will ask me if it's genetic. You know, my grandmother had Alzheimer's disease. Does that mean that I'm more likely to get it, right? Is it genetic? And so what we know in Alzheimer's disease is that genes contribute very little variance to whether or not a person has the disease if it's late onset. So if a relative gets Alzheimer's disease after the age of 5, younger person's risk really isn't elevated that much, if at all. However, if a family member gets Alzheimer's disease before the age of 65, if they get early onset Alzheimer's disease, then that does increase your risk for developing it yourself later in life. Okay, so the only reason we distinguish that is really for prognosis of other family members. My favorite, people will always ask, they want to know what stage of Alzheimer's is it? Is it mild? Is it, what is the stage? My favorite staging system is actually the Alzheimer's Association staging system. This is my favorite. There's lots of different staging systems out there for Alzheimer's disease. Without a doubt, my favorite one is the Alzheimer's Association staging system because it's based on behavior. It's based on observable behaviors that anybody can witness and engage. There are staging systems that are based on the level of cognitive impairment. Do you have mild, moderate, or severe cognitive impairment? There's those that are based on pathology, where the only way to stage the illness is to wait for the person to pass away and then go in and see where the pathology is and the burden of pathology. And what I like about Alzheimer's Association system is that it's just so very clear and so behaviorally based. And so in stage 1, there's no impairment. The person doesn't experience any memory problems, thank goodness. Stage 2 would be very mild cognitive decline. We start to see that the person feels as if she's having memory problems. So the patient themselves starts to notice that their memory isn't as good as it used to be, but nobody else notices, right? Coworkers don't notice, family doesn't notice. Only the patient themselves kind of notices that their memory isn't as efficient as it used to be. Okay. Mild cognitive decline. Now we start to notice problems with coming up with the right words or the right names. The word finding, the language problems start to emerge. Trouble remembering the names of new persons. So I think right now I just met Anne. I still remember Anne's name. So I'm still okay. Thank you, Anne. Okay. I remember Esther from last night. So I'm good. Okay. Trouble remembering the names of new people. Having greater difficulty in performing tasks in social or work settings. So maybe when they're at home, they're okay, but once they have to do tasks at their job, they're not able to do those as efficiently. forgetting material that's been read. They start to lose or misplace things, misplacing their keys, harder time planning and organizing. As the disease continues to advance to moderate cognitive decline, now they become more forgetful of recent events, greater difficulty performing complex tasks, forgetful about their own personal history. Usually it's their medical history. They can't give their medical history anymore. And then they start to become moody or withdrawn in socially challenging situations. This is the stage here where I start to see them in my clinic. It's rare that I'll have someone in my clinic before they've reached this stage here. However, as the disease advances, now they're unable to recall their own address, their own telephone number. They struggle to remember their high school or the college they graduated from, more confused about the time of day. They need help choosing proper clothing. And however, their basic activities of daily living are still preserved. They don't need help with grooming, showering, toileting, that kind of thing. It's the severe cognitive decline. Now they start to lose awareness of recent experiences, difficulty remembering their spouse's name or their caregiver's names. They need help getting dressed. They need help with their basic activities of daily living, like toileting. So now we're at we're now in this stage here, we're sort of in a assisted living level of care range, and in this stage here, we're now more in a nursing home level of care range, right? Once they get to stage 6. And then finally, very severe cognitive impairment, definitely nursing home, bedridden, struggle to swallow, muscles are growing rigid, poor reflexes. And so the average amount of time, from the time of diagnosis to the time of death, the average amount of time from the time of diagnosis to the time of death is 10 years. That's the average amount of time. From diagnosis to death, average amount of time is 10 years. But how long have they had the disease before they were diagnosed? It's hard to say, right? It's hard to say. They just haven't come to you or come to your clinic, right? So often they've had the disease for years before they come to you, right? And so from diagnosis to death, average amount of time is 10 years. But often they've had the disease much longer than that. So when we do the, again, kind of starting to think about cognitively, about the Neuropsych testing, this is that clock drawing task that I was telling you. I want you to draw a clock that says 1:45, set the hands and numbers on the face so the child could read them. You can see here that in a healthy elderly, well elderly, that they are able to do that pretty well. This elder has a tremor. You can kind of see that he has a tremor. But people aren't disabled by their tremors, right? Tremors are not disabled. And so it's a little shaky, but he does a good job. Here, now he's just looking at a clock and copying it. You see he does a good job there. By the time we get to end-stage Alzheimer's disease, this is what we get, right? They can't draw a clock to command, they can't copy one, and you can just see that Alzheimer's is taking away all cortical function. If you look at Alzheimer's disease if you look at the brains of patients with Alzheimer's disease, this is what you'll see. So good, healthy brain here. On the left, you can see the memory areas. That's the hippocampus right there. That's the part of your brain that encodes new memories. You can see it's nice and full there. This is language areas. And if you compare normal tissue with Alzheimer's disease, you can see that the memory areas are just ablated. That hippocampus is gone, right? It's just gone. There's no registering new memory anymore. And you can see the language areas are gone as well, right? They're just obliterated by pathology. You can just see that the whole brain is just smaller, right? That's just smaller, it's just atrophied. You can see the ventricle is so much bigger here than it is over here, right? The ventricle. Yeah, these are age matched. Yeah, these are, No, these are age matched. These are age matched. And so you can see just how the pathology is just tearing away at the brain, right? It's just killing off the nerve cells as it progresses. If you look at Alzheimer's disease under the microscope, this is what you see. These are called tangles. This is a nerve cell. This once was a nerve cell, and now it's just filled with this dark protein that has killed it. And these right here, these extracellular globs here, those are plaques. Those are beta amyloid plaques. And so if you look at Alzheimer's disease under the microscope, you'll see tangles, nerve cells that have been killed, and you'll see plaques, extracellular protein deposits. What predicts the functional and cognitive decline of Alzheimer's disease is the tangles, right? Is the tangles. So where in the brain is the very first place to get tangles? Where's the very first place in the brain to get tangles? No. So tangles they don't just show up. It's not like mushrooms growing in a field. It doesn't just like show up everywhere, right? The very first place in the brain to get tangles is your pre-olfactory cortex. That is the part of your brain that allows you to identify smell. The very first place in the brain that you get tangles is right up here. It's your pre-olfactory cortex, the part of your brain that allows you to identify smell, right? So in the clinic, one of the things that we can do is we can like take advantage of this. We can ask patients, we can have like a little vial of coffee or peppermint or whatever. We can tell them to close their eyes, and we can just say, hold it under their nose, and we can just say, what does this smell like? Now the question is not, can you smell this? Can you smell this isn't the question you ask. Okay, you're not going to ask, can you smell this? You ask them to identify the smell. Tell me, what does this smell like? And if they say, oh, that's coffee, and they're correct, chances are they don't have Alzheimer's disease, right? Chances are if they can identify the smells, they don't have Alzheimer's disease. If they can't identify the smells, it doesn't mean they do, right? If they can't identify the smells, it doesn't mean they do, because there's lots of reasons why we might not be able to identify a smell. Okay, there's lots of reasons why we might not be able to do that. But if they can identify the smells, then it tells us that it's less likely that they have Alzheimer's disease. There's actually a formal smell test now called the UPSIT for helping with the diagnostic clarification of Alzheimer's. FDA-approved medications for Alzheimer's right now, this is it. One of the saddest talks I've ever had to give in my life was at the University of Texas Austin Psychopharmacology Update conference. This was last year, and they wanted me to give a talk titled "Updates in Geriatric Psychiatry Pharmacology," and I had to stand up there and say, there have been no updates in geriatric psychopharmacology. Like the saddest talk I've ever had to give. And so these medications have been around forever, right? Donepezil is Aricept, rivastigmine is Exelon, galantamine is Rizadyne. These are the three that are prescribed. We don't prescribe TAC anymore. That causes liver failure. But these three right here are very commonly prescribed. And then the newest one was memantine, which is Namenda. Namenda came on the market in 2003. So there have been no FDA-approved medications for Alzheimer's disease since 2003, right? So this was like the saddest conference I had to give to UT Psychopharmacology. But, you know, I was the last speaker of the day and everybody got to go home early, so it was good, right? That was good. So, the way those medicines work, the way donepezil and rivastigmine and galantamine work, is they prevent the breakdown of a chemical in your brain called acetylcholine. Acetylcholine is a chemical in your brain that allows you to focus and concentrate, right? And through that focus and concentration, it may enhance memory. It may, okay? It may. Some of the ways people can relate to this is there's nothing that increases acetylcholine or acts on acetylcholine receptors better than smoking, right? So you can kind of, you know, there are people, if you have friends or family who have quit smoking, one of the things they'll complain about is that when they quit smoking, they're just not able to concentrate like they used to be able to. They're not able to concentrate like they could when they were smoking, right? And that's because of this increased chemical called acetylcholine. So those medications prevent the breakdown of this chemical. And then memantine prevents too much calcium from entering nerve cells. So the idea is that if too much calcium enters the nerve cells, then calcium can cause free radical damage, and that free radical damage will kill the neuron. So maybe by preventing too much calcium from entering the nerve cells, we can protect those neurons from free radical or oxidative death. Okay? For these medications, I can tell you that I think my experience is the challenging thing about these medications is that you can have an expert panel of Alzheimer's. You can have Alzheimer's disease experts. You could have 8 experts on stage, and if you ask them their opinion of the medication, you'll get a range of opinion from if patients with Alzheimer's disease are not on these medications, the doctor is violating the standard of care, all the way down to there's absolutely no reason for these medications to ever be prescribed because their effect sizes are so small that all they do is cost money, okay? And so that's the challenge with these medications. I can tell you personally for these medicines, sort of anecdotally, it seems to me that about 1 in 8, I'm usually convinced that about 1 in 8 of my patients are benefiting from them. So that's, 1 in 8 is enough for me to continue to try to use them and see if they'll help, but I'm never excited to prescribe them. I never tell a patient, wow, have I got a medicine that's going to change your life and keep you out of the nursing home? I'm never excited, right? So that's the challenge with these medications. Sure. Okay. So all of those medications have some demonstrated efficacy. Their effect sizes are small. Few show improvement. And people always want to know, what can I do to prevent Alzheimer's? Like, what can I do? What can I do to prevent Alzheimer's? And what's the answer? It's up there. Exercise. That's like the only thing. When you look at what can a person actually do to protect their brain? There's just nothing better than exercise. And people like the idea of sitting in a big, comfortable chair and doing crossword puzzles. What if I just sit? And sometimes families take it to the extreme, right? Where they're like chaining their loved ones to the table and making them do crossword puzzles, right? So I probably shouldn't say that with APS in the room, but nonetheless. So I always tell families, do not torture your loved one with crossword puzzles. There's just no substitute for walking 20 minutes a day, every day. That's what prevents, that's what the literature clearly shows prevents Alzheimer's disease and other comorbidities better than anything. All right. So the question is, well, how does that help? How does that help? So there's a few things. So we kind of start to go off into neurochemistry. And so, without talking too much about that, there's a factor in your brain called BDNF, brain-derived neurotrophic factor. Brain-derived neurotrophic factor, or BDNF, is a chemical in your brain that nourishes, protects, keeps the neurons functioning and more efficient. And when you exercise, levels of BDNF go up. There's not a doubt about it. No doubt about it. The other thing that exercise does is it protects you from cerebral vascular disease. So there is nothing that will cause you to lose your memory quicker than a stroke. Right? And so it protects your brain in that way also against kind of stroke, against cerebral vascular disease. But the chemical, the actual exercise chemical, the chemical that is elevated is called BDNF, brain-derived neurotrophic. Okay, moving right on. Second case. So, 73-year-old man comes to clinic with his wife. She expresses concern for her husband, saying, I think he's depressed. He just sits in his chair all day, doing nothing. I have to do everything, right? So, his diagnosis is that he's a man, right? Okay, so I think he's depressed. He just sits in his chair all day, doing nothing. I have to do everything, right? So he no longer manages the finances like he used to. He doesn't take his wife now has to kind of manage his medications. And he says, I don't feel depressed. He thinks I'm depressed, but no, I'm not depressed. Okay, so he doesn't feel depressed. He doesn't understand his wife's concerns. He takes medicine for diabetes, high blood pressure, elevated cholesterol. He had a heart catheterization for coronary artery disease about 5 years ago. He had been a salesman. He's been married to his wife for 22 years. They have 3 adult children. He's smoking a pack a day, drinking 6 to 12 beers a week. So when we do his neuropsych testing, he cannot draw a clock either. He is executively impaired. Where's executive function? Frontal lobe. Man, look at y'all. This is like learning. This is great. Okay, good. Executive function is frontal lobe impaired. But when you ask him to copy a clock, he can't. The cut point for a fail on that is a 13. He can't. So he can't draw a clock on his own, but he can copy one. I told you the cut point for the mini-mental is a 24 or below. He passes the mini-mental, right? That's a passing score. So he knows the date. He probably remembered 1 or 2 of the 3 words I asked him. When the words that he didn't remember, when I gave him a hint, they came back, right? One was a piece of furniture. Oh yeah, that was the table, right? He gets that's a memory measure right there. He gets a perfect score on a memory measure. His memory just isn't that bad. And so this is an example of vascular dementia, right? These are the vascular dementia cases we see. The cases where people come to me telling me that they think their loved one's depressed because they're not doing anything. So one of the things in my clinic that I'm always trying to distinguish between is depression versus apathy. Depression is hopelessness, helplessness, worthlessness. It's crying episodes. It's thinking that life is no longer worth living. It's thinking that you'd be better off dead. Apathy is just doing nothing. Right? Apathy is not being motivated. It's not having energy. It's not having any drive. Apathy is just apathy. So when people come to my clinic, I'm trying to figure out, are they depressed or are they apathetic? And this is apathy. So what we'll see in vascular dementia cases, you also see that he has all these cerebrovascular disease risk factors. He's smoking and all of that. In vascular dementia, they'll have all these risk factors. Their memory just isn't that bad. And they have much worse executive function and complex processing than memory impairment, right? Their memories aren't that bad. For vascular dementia, what we'll see is they cannot draw a clock to command. You can see doesn't look anything like a clock that says 1:45. But they can copy it just fine, right? So he has impaired frontal lobe, but his posterior cortical features are fine, right? This part of his brain is not diseased, right? He has isolated frontal lobe disease. And so if we look at vascular dementia on the whole brain, these little purple dots that you see here, so here, all these little purple dots. I had like too much coffee this morning. There. Those dots, those are strokes. Those are little itty bitty tiny strokes. There's no such thing as having a small stroke. Sometimes I'll have patients who'll come to my clinic and they'll say that. They'll say, I had a small stroke. It's like being a little pregnant. Right? A small stroke, just a little pregnant. Okay, so the types of strokes that happen here, they don't affect you like strokes normally do, right? So normally when we think of people having a stroke, we think that they've lost, motor function on half of their body or sensory function, that kind of thing. So the strokes aren't big enough. These aren't big cortical strokes that do that. These are just tiny little strokes that happen in the front part of your brain or in regions deeper, and they don't cause motor impairments, but they do cause cognitive impairments, and what they really cause is executive function impairments. If you look at their brain under imaging, these white splatches there, those are strokes, right? These white splatches here, those are all strokes. And so that's what they look like. So when we're getting MRIs for patients, again, we're kind of trying to figure out what the diagnosis is. This helps. And so these imaging studies will be read out as periventricular white matter disease is usually what it'll say on the radiology. And so the treatment for vascular dementia, you have to prevent stroke. So this is, the aspirin, the exercise, anticoagulants like Plavix, for example. We have to prevent future stroke. So what will happen with Alzheimer's disease, cognitive and functional decline are just continuously going down. They're just going down. For vascular dementia, it's a different pattern. What will happen is that someone will be at a given level of function. They're at this level of function and this level of cognition. And then they have a stroke and they drop down. And now they're at this level of cognition and function until they have another little stroke and they drop down. So it's more of a stair-step pattern, right? It's more of a stair-step. So if you can prevent future strokes, you can put them on aspirin, get them exercising, put them on Plavix, Coumadin, whatever it is. If you can prevent future strokes, then they can stay at that level of function. They don't have to get worse. Right? In vascular dementia, you don't have to get worse. And so that's why also in vascular dementia, when you ask family members, when did you start to notice problems, they're able to tell you. They're able to know that, whenever that little stroke happened, they're able to kind of zone in around that period of time. And all the family members in the room will say the same thing. They'll say, oh, it happened whenever. 6 months ago is when we noticed problems, and we all noticed them at the same time. The other thing that we'll see, the other kind of common presentation that I'll see for vascular dementia has to do with orthopedic procedures. It has to do with orthopedic procedures, like knee replacements. So, so often I'll see in my clinic, patients will come in and they'll say, my dad just hasn't been the same since he had his knee replaced. He just hasn't been the same. He hadn't been the same since that knee was replaced. And so one of the things in orthopedic procedures like shoulder replacements or knee replacements, a lot of times what the surgeons and the anesthesiologists will do is they'll lower the blood pressure. Right? During the surgery, they lower the blood pressure to keep the field dry. So it's not all bloody when they're in there, doing their thing, right? So they'll lower the blood pressure. But if someone has all these cerebrovascular disease risk factors, when that blood pressure is lowered, they hypoperfuse the deeper parts of the brain. They get these strokes, for lack of a better word, and that can lead to kind of this vascular dementia type picture. So patients will say, my dad hasn't been the same since he had that knee replacement. Do you think it was the anesthesia? I think it was the anesthesia. The anesthesia. But it's not the anesthesia. It's that hypoperfusion during the surgery itself, right? When they're keeping the field dry. So I always tell my patients, there's no such thing as a small stroke, and there's also no such thing as a minor surgery, right? And so we have to really, for our elders, our frail elders, we have to really think about kind of the risks and benefits when we start replacing knees or whatever in 85-year-old people, right? We have to really, really think about that. So the question is, so once that happens, is there any recovery? Can you recover from that? Sometimes you can. Sometimes the brain will rewire, right? It can rewire, but often not. Often it's just kind of, they're sort of more dependent now. And the question is, can that happen at any age? It can happen at any age, but it's really elders. It's elders, and it's elders who have a lot of these vascular risk factors. So like healthy elders will be fine, right? They can be fine. But it's the elders who've had, coronary artery disease, they have diabetes, they have hypertension, they have hyperlipidemia. For patients with vascular risk factors, we really start to have to think about the potential risks and benefits. Let's see here. Okay, next case. 93-year-old woman is brought to the clinic by her daughter. The patient lives with her daughter. The daughter reports significant cognitive decline and functional decline over the past 1 to 2 years. The patient reports occasionally seeing little men walking across her mantle. Right? She has these visual hallucinations of these little guys that just keep walking across the mantle. She was started on an antipsychotic. She was started on risperidone, in fact. And when she got risperidone, she had this really bad dystonic reaction. Her head was locked over to the side, and she couldn't look forward anymore. So she had this really bad muscular contractual reaction when they tried Risperdal to treat the little men walking across the mantle. And then the daughter also says that this patient just, she moves in her sleep. So she does lots of sleep talking, and she's just always moving around in her sleep. She kicks and kicks and kicks. And in fact, when before the patients moved in with the daughter, her husband was alive, and the husband couldn't be in the same bed as the wife, because he would just get beat up every night they went to bed because of all the kicking and the flailing and all that kind of stuff in the sleep. She takes medicines for heartburn, she has incontinence, she has constipation, she has high blood pressure, she has atrial fibrillation, so the heart rhythm isn't as synchronous as it should be. She's had all these falls. Social, she's 12th grade education, housewife, she's been widowed for about 12 years, no substance use history. When we do her neuropsych testing, she draws this little bitty clock, right in the middle, right? You got this whole page, and she does that, right? There, I'm done. There. So she's failing clocks 1. She can't draw a clock 2 command. She can't copy 1 either. Her mini-mental is just below the failing. It's not terrible, but it's just below the cut point. So what kind of dementia is this? Lewy body. And what made you say Lewy body? The little people. Little people. That's right. Yeah, good. So for Lewy body, there's a triad for Lewy body. So the triad for Lewy body is you have to have dementia, you have to have cognitive impairments, you have to have functional impairments, but in addition to that, patients with Lewy body dementia will have visual hallucinations, Parkinsonism, and then fluctuations of attention. And so visual hallucinations, the visual hallucinations of Lewy body are incredibly vivid. Incredibly vivid. So this isn't like people who say that they're seeing shadows out the corners of their eyes. It's not that. It's, I see little people walking across the mantle right there. It's, where did all these cats come from? Who left the door open? I told you if you leave the door open, all these cats are going to come into the apartment. And look, here they are, right? They're incredibly, incredibly vivid visual hallucinations. Incredibly vivid visual hallucinations. The Parkinsonism, we don't see kind of the classic pill roll and tremor a lot of the times. We don't see that. But what we'll get is the stiffness. So they'll get cogwheeling. If you kind of move their arms up and down, they don't move in a nice steady motion. They just kind of ratchet, ratchet, ratchet. So lots of stiffness. What else? We get the micrographia. So that right there is micrographia. Patients with Parkinson's write very small, right? And so here you see micrographia as an example of Parkinsonism. And then for the fluctuations, there's times when they just seem fine. And then it's like a light goes off and they're just disoriented and lost in space. And it's kind of a sundowning type phenomenon, right? They're just fine, 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 fine. And then from out of nowhere, they're just more confused and more disoriented. And so the core features of Lewy body are these fluctuations, visual hallucinations, and Parkinsonism, right? They have these Parkinsonian features. The other problems that they'll have are REM sleep disorders. So normally when you're asleep at night, your brainstem paralyzes your motor systems so that if you dream that you're running, you're not actually in bed running, right? So that's what normally happens. But in Lewy body dementia, their brains will fail to do that. And so these are the patients who are talking in their sleep. They talk and talk and talk in their sleep. They're flailing all around. Their spouses have to move to a different bed. They have these REM sleep disturbances. They're very sensitive to psychiatry medicines. The antipsychotic medications like risperidone, olanzapine, quetiapine. So this would be like Seroquel, Zyprexa, Risperdal, medicines like that. They go through that. They fall. The other catch is that they fall all the time. So these patients are just always. If I went to a nursing home and I said, bring me the last 20 patients you've had that have fallen, 12 of them will probably have Lewy body dementia. So these are the patients that fall all the time. And then their medical histories are never none. They always have these rich medical histories. And so their medical histories, it's like their whole autonomic nervous system, the part of their nervous system that controls just sort of the internal physiology of their body, is just turned upside down on its head. So these are the patients that anything that you do, your nervous system does automatically, just isn't working anymore. So now we get the incontinence, we get the increased acid secretion in the stomach, we get diarrhea or constipation, the heart arrhythmias, the whole autonomic nervous system is just turned upside down on its head. And so their medical histories are also very rich, unlike patients with Alzheimer's disease. And then, if you look at it under, the reason it's called Lewy body, that big old purple thing right there in the middle, that's a Lewy body. You have these proteinaceous deposits in the brain, and the pathologist was named Dr. Lewy, and so that's an example of a Lewy body right there. So in Alzheimer's pathology, you have the tangles and the plaques. Lewy body dementia, your brain starts to fill up with those. Good. I'm sorry. So sensitivity to antipsychotics. So they have bad side effects. So if you prescribe antipsychotics like risperidone or olanzapine, should be Zyprexa or Risperdal, and Haldol, incredibly sensitive to Haldol. You give a patient with Lewy body dementia Haldol, their head may never point straight again, right? I mean, it can just lock into position, right? And they get these incredibly. Right, so it's saying that they end up with physical problems, lots of physical muscular problems. And then, sir, you were saying? So the question is, what's the difference between plaques and Lewy bodies? It's just the type of protein that's secreted. It's just a different protein. That's it. It's just a different protein. Okay. So the last case. Oh no. Okay. So the last case we'll talk about. This is a 60-year-old woman reported for self-neglect. So the first thing that I'm going to draw your attention to is 60 years old, right? A little younger. She's living in squalor, no electricity, water, or sewer. The client's had $2,000 past due on her water bill. APS is involved. They facilitated a voluntary placement, but it all has to do with the dog, where she goes. She was allowed to take her dog, but then she became upset. They wouldn't let her have her dog, and it became all about the dog. When I asked her kind of like what her plan is to get those utilities back on, she says, well, she's going to call Channel 4 News, and she's going to have them help her do a little fundraising. Okay, so some fundraising through the local news is what she's planning on. We go to her house, it looks like this, classic APS house. So she doesn't have any water, so the tub's filled with feces and all that. You can see the ceilings falling in. That's the kitchen sink right there. You can see her kitchen sink that's the kitchen sink there. The kitchen's falling in. So we go to this house, and there's this lady who's only 60 years old, and she has this sort of chaotic story, and we do neuropsych testing. That's pretty good, right? So we'll talk about that. Remember that clock. I'll show you that clock again. That clock's not going to go away. Right? So she draws that right there. What I want is she gets a perfect score on memory, a perfect score on the mini-mental. She fails the executive function task. In fact, she fails both of the executive function tasks. But she can copy a clock just fine. So she has isolated frontal impairment, and her memory is perfect. Her memory is perfect. Okay? Her memory is perfect, and yet that's how she lives. Right? Her memory is perfect. So maybe memory isn't that important. Right? Maybe not. Okay. All right. So what type of dementia is this? So this is frontotemporal dementia. This is FTD. This is frontotemporal dementia. And so frontotemporal dementia is what you get when you're young. Frontotemporal dementia strikes between the ages of like 55 to 65. You get FTD when you're young. And the way this most commonly presents to my clinic is someone will bring their loved one and they'll say, Doc, I think my dad has new onset bipolar disorder. Right? I think it's new bipolar disorder. And I'll say, well, tell me about that. And they'll say, well, I mean, he's just he has these kind of new sort of hypersexual behaviors that he's doing. He's incredibly impulsive. He's incredibly disinhibited. He's not getting anything done anymore. We're having to help him. He's incredibly resistant. And so they'll think that, you know, he just seems kind of manic-like. But he's not manic, right? He's sleeping fine. He's eating fine. He doesn't have a sense of euphoria, right? There's no mood disturbance like we see in bipolar disorder. Bipolar disorder, you don't get bipolar disorder from out of nowhere at the age of 60 unless you've had like a stroke that's causing it. So it's not bipolar disorder, it's frontotemporal dementia. And so what we'll see with frontotemporal dementia is, so this is a brain here, you can see that the back part of the brain is completely fine, and the front part of the brain is incredibly small and withered, right? Back part of the brain, completely fine, good cortex, but the front part is atrophy, right? Totally atrophy. And if you look at FTD under a MRI, again, you can see the back part of the brain, completely fine. Front part of the brain, it doesn't even make it to the skull, right? It's completely atrophy. Over here, back part, fine. Front part, eaten away, right? That's FTD. So can you get this from a traumatic brain injury? That would be a different type of dementia. You can get the same behaviors as this from a traumatic brain injury, but the pathology would be different. Right? So the pathology of FTD is called pig bodies. These are examples, these little brown things are pig bodies. Like there's Lewy bodies, there's tangles, these are pig bodies, just a different protein, but the disease process is eating away at the front part of the brain. Okay? So again, just in sum, there's major neurocognitive disorder, To have major neurocognitive disorder, that term has sort of replaced dementia in the new DSM-5 language. To have major neurocognitive disorder, you have to have cognitive impairments, you have to have functional impairments, and the cognitive impairments have to be causing the functional impairments. There's lots of different cognitions. There's much more cognition than just memory, right? There's visual spatial, there's executive function, there's social function. There's lots of different types of cognitive impairments. And then there's also lots of different types of dementia or major neurocognitive disorders. It's not just Alzheimer's, 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 Alzheimer's. And the group that will tell you that first is the Alzheimer's Association. It will say we help families with Alzheimer's disease and other dementias. Okay? So with that, we have like 10 minutes for if there are any questions before break. So the question was kind of flip back to, that would be the behavioral variant right there. So let's see, why don't we, so I don't have to keep repeating the question, maybe we can use the microphone, so I'll get to you. Yeah?
I'm kind of curious to know, is there any type of dementia that can come with like a seizure?
So are there dementias that can come from seizures? The answer is yes. Yeah, so if a person has a seizure disorder and they keep having seizures and uncontrolled seizures, absolutely their brain can dement from that. Absolutely. I've seen that. It's so sad when that happens. So the answer to your question is yes. Chronic uncontrolled seizure disorders can lead to these cognitive impairments that can lead to disability. Sir? Aluminum. Okay, so there's questions, is it possible that aluminum causes Alzheimer's disease? Right? Because there have been associations. I think that's been pretty much put to rest. I think so then the question is if it's not aluminum, what is it? Like, what is it? Other environmental factors, like what? What causes Alzheimer's? So like the very first place in Alzheimer's disease, the very first place in the brain that gets Alzheimer's disease is the part of your brain that identifies smells. So the first place you get it is in your nose. The next place you get it is in perineurital cortex and then in your hippocampus. And you start having memory impairments. From there it spreads to a structure called your amygdala. Once it gets to the amygdala, you start to become suspicious. You start to think that people are stealing your keys. Someone stole my wallet. You get kind of grumpy old man syndrome. Get off my yard, you kids, right? And then from there, the pathology spreads into the frontal lobe. You become executively impaired. Once you become executively impaired, you become disabled, and now you become demented. So Alzheimer's spreads very sequentially through the brain, and it starts with the nose. So kind of the leading thought right now about what might cause Alzheimer's disease is viruses, actually, because they could penetrate through the nose. And the actual type of virus that people have their eye on are herpes family viruses. Because we know herpes viruses spreads retrosynaptically through nervous tissue. That's an idea. Other questions before the break? Oh, in the back there, in the boy.
Are you familiar with University of Florida's study with peanut butter?
Can you tell me that?
Yeah, they take peanut butter and they, the person can't see, they're blindfolded.
Uh-huh.
And they have a yardstick, a measuring stick, and they have them close one nostril and inhale through the left or the right first.
Okay.
And stop when they smell it.
Yeah.
And what they're finding is that people with Alzheimer's, I could probably get this backwards, the left side picks it up first,
Yeah.
and the right.
Yeah, it's known that the left side of your brain, let me get this right. Actually, it's the right side of your brain ages faster than the left side of your brain. The right side ages faster than the left side. And so the left side is verbal skills. Verbal skills. And that's why, maybe why crossword puzzles aren't quite as effective, because they're verbal and you're aging less fast than you're right. So then the question is well, what type of mental exercises stimulate the right side of your brain so that it doesn't age as fast? So what would those be, you know? What could you do to help your right side of the brain age less fast?
So he presented this thing, and Mayo Clinic came out and said, David Cotton, I think it was, that said this is probably garbage, but I haven't read anything else since on somebody either supporting it. I haven't seen it peer reviewed.
Yeah. Yeah, there's a lot of water under the bridge where it's known that the right side of the brain just seems to age faster than the left side. And I'm wondering if that study's maybe tapping into that. So things that people can do to help their right brain are things like mazes, right? Because that's very visuospatial, kind of like working those maze books or whatever. Or music. Music's another thing that activates the right side. So maybe that Florida study's tapping. Jigsaw puzzles, very visuospatial, right? That's very visuospatial, jigsaw puzzles. Good. All right, well, why don't we take a 15-minute break, and then we'll keep moving through.
Yes, ladies and gentlemen, go ahead and visit the vendors, use the restroom, grab some more snacks, and we'll resume at about 10:45 sharp. So we'll be back in about 15 minutes or so. Thank you. Can you make sure your mic is on?
I don't even have it.
Okay, okay.
Yeah, it is. And then, if you want to know if someone
There you go.
ask their spouse.
We're gonna do about 5-door prices while we're here, and then we'll do the rest this afternoon. Take out your little blue ticket, please. And then Gustavo, will you help me? $344. It'll be the last 3 digits. 344. 344 going once. Twice. Okay, come on. Come on up quickly.
Working, man. Staying busy. Yes, they're talking to mine. They were the same ones that we put in on the
260. 260. And a Chili's gift card for $25. Anybody? 260? There we are. Okay.
It's a nice one. He works. I can only have my half power now.
And what is your name and what is your institution? Oh, excellent. Thank you so much. Okay, it's 254, and that is for a $25 gift card to Gap, Old Navy, Banana Republic. 254. Excellent. What is your name and? Oh, we got a dad's here. All right. There you go. Our next prize is it's a camera, a Coolpix L610 with a 4 gig memory card. Wow. Okay. Wow. Okay. Number is 377. 377. There we are. Down there. Woo! Yeah. Okay, name and institution.
My name is Judith Boyain, and I'm from Retama.
Wow, this is a $50 gift card to Barnes & Noble. So if you're a reader, you want to get this one. Number is 230. 230. 230. There we are. Wow. Very good. Congratulations. Name and institution, please.
Janie Gaitan, Ebony Lake,
And just to note, all these gift prizes are being brought to you by Doctors Hospital Renaissance. Thank you very much for that. Wow. And this one from AAA. Oh, they got their own door prize thing going on. You want to pick it up? Grab one from here? Oh, they got their own little booth thing going on. 551, 551, 551. Anybody? There we go, we got a winner. Big basket from the AAA. You better not work for the AAA. Name and institution, please.
My name is Lupita Cuellar, and Activities Director for McAllen Nursing Center.
Excellent, thank you, congratulations, okay. Okay, these are for the centerpieces at your table, the flowers on your table. So if you win, the one on your table is the one you take home. Don't take it home now. Just wait until the conference is over and then take it home. Okay, the winner is the table that belongs to 274. 274. Raise your hand, nice and high. There you go. Okay, congratulations. That is yours. Take care of it. Water it, take care of it. Number 412. 412. Hands high. 412 must be here to win. There we go. All right, one of our volunteers. Excellent, you deserve one. Number 288. 288. Hands nice and high. Must be here to win. 288. Going once. Going twice. 288. Come on. Gone. Next. 318. 318. Can you see some hands? Really? Nobody wants these? 318. Check, double check, triple check. Gone. 264. 264, come on. 64 right there. All right, that is yours to keep. They're real flowers, they're not fake or anything. They're fresh flower. Okay. 366. 366. 366. Winner right there. Lady in the black sweater. That is yours. Keep an eye on it. You might sit there. 255. Last one. 255. Right there. Is that yours? Okay, excellent. That's yours right there. All right. Thank you so much for participating and going to the vendors and coming in today. Thank you so much for those. Those are it. Throw that one away. Thank you very much. Okay, in a few minutes, thank you for everything. Doctors Hospital and Renaissance, everyone. Thank you. Great prizes. Not bad for a free conference, huh? Not too shabby. Okay, in a minute, Eliseo from the Alzheimer's Association is going to come up here, give a short talk about the Alzheimer's Association, and then we'll resume our lunch. And in about another 30 minutes or so, we'll get ready for our next talk with Dr. Schillerstrom.
Good afternoon, everyone. Please continue with your lunch. I'm just going to share two quick resources that you could access on your computer and also just by picking up your phone. My name is Eliseo Chavez. I am the representative for the Alzheimer's Association. So I work with Corpus Christi and the Rio Grande Valley. All this week I've been in the valley. And just wanted to emphasize, you've probably seen on one of the slides, the website, aoc.org. When you go there, great information. On the right-hand side of that website, there's a section, if you're a caregiver, you click on that section, Caregiver. Please emphasize that website to families. It has great information, a website dedicated just to caregivers. Information about communication with somebody with dementia, behaviors, driving and dementia. Brochures like the ones that you probably picked up, like this one. They're all there on PDF, so you could just download them to your computer or to your tablet, print them, have them for your staff or for families if you want. So great information, AOC.org. The other resource that I just wanted to talk to you about, on back of all brochures, it's got the 1-800 number. The 1-800 number is 24/7 helpline for the Alzheimer's Association. 20,000 calls come in per month. So please use that 1-800 number, share with families, anybody that has questions about brain health. That is the number. It's available in 170 languages. A lot of families in the Valley are using it, of course, for Spanish, but many families are not aware of that helpline. That is a 24/7 helpline for Alzheimer's, just dedicated for Alzheimer's. So if you need some information, if you have not gone by our table, please drop by. We have some great information in Spanish, English. They're available for you. So thank you so much.
Won't you see about me? I'll be alone, dancing, you know it, baby. But telling me your troubles and doubts, giving me everything inside and out of world. Well, love's strange, so real in the dark. Think of the tender things that we were working on. But slow change can pull us apart. When the light gets into your heart, baby, well, don't you forget about me.